bottom of the screen. And if you would like to speak, please either push the raise your hand button at the bottom of the screen or fold a piece of paper in half and hold it up. And please announce yourself when speaking, especially if you're on the phone. So at this time, I'll turn this back over to David. Thank you.
Wonderful. Thank you, Melanie. And now I would invite our Executive Director, Mr. Ben Steffen, to make some remarks.
Yeah, thank you, David. I think if everyone tries to keep their phone muted, it's probably going to be more effective. I want to first of all thank everyone for joining us on short notice. Recognize the MHCC team that's put this all together, and lastly, give a call out to everyone. We've been through a process over the last 9 months. Now CMMI has really drawn a line, and I think it's very important that all the state representatives work together at this point to reach a consensus on what we all can agree to, recognizing that there's going to be some need to compromise, but the goal has to be to put something forward to CMMI that can be both workable for us and acceptable to them. That's the top priority given the amount of time that they've given us to react. So I'll pass it back to you, David.
Thank you. And Dr. Riedman, did you have a couple of qualifying remarks to Dr. Haft's presentation?
No, I just wanted to say that we really did want to, like I said a minute ago, get ahead of the committee. And this has been a very fluid process over the last, in particular, 3 to 4 weeks or so. We've gotten a couple of feedback responses and meetings with CMMI, which Dr. Haft will go over, but we just wanted to again update the committee. We're not going to have time for a lot of discussion tonight, but we did have some ideas and wanted to get some feedback, which we'll hopefully do by email. But there is a time constraint, which we'll talk about, Dr. Haft can review. But again, I'll turn it over to him in the interest of time, and we'll move forward from there.
And Dr. Haft, is it your preference that we moderate the questions and hold them to the end, or is it your preference to take questions on each particular slide, if that's the case?
Well, let's. I think for the sake of time, since we only have half an hour, let's go through the slides and then we'll see what questions are at the end.
Okay, thank you, Dr. Haft. Please proceed.
Okay. Well, again, I thank the advisory council members for all the work they put in over the last 9 months, and things, as they often do, continue to take twists and turns. Some are expected, some are not. But I just wanted to make sure that we brought you up to date on where we left off when we last spoke, which was in the year of 2020, and where we've gone since then. So as you recall, at the end of 2020, at 12/23, we submitted Track 3 recommendations to CMMI from the PMO and from the Secretary, and also a corresponding letter from the Advisory Council. We received a response to those recommendations on February the 9th, and then following that, CMMI and the state attempted to do what we could do to address what the remaining issues were. The most significant remaining issue was that there was a very large practice level variation in the total primary care payment. This is before performance adjustments. And we labored back and forth with our contractors and their contractors doing modeling to reduce that very significant total primary care payment impact, which was just based on the transition from Track 2 to Track 3 with no other taking care of the same patients. We failed to do that. We made many attempts at doing that and ultimately could not wring out that. CMMI came back on April 29th and said, well, based on that, here are 3 options. And we'll go over what those 3 options are now. And they said they would like a response. They need a response by May the 14th. So we're now 10 days away from that response time. We'll go on to the next slide. So here's a graphical representation of what that difference was that really stumped us. And this was even after doing modifications to HCC scores and looking at many, many different ways. We found that again, before any performance adjustment, before the -10 to +25%, and for the total primary care payments for Medicare, that 9 of the 36 practices had adjustments that were negative in the very significant range of up to 40%, and that an additional 60. Well, let me get the number here. 57 of the 367 practices had more than 10% negative adjustment, and that was unrelated to any feature that we could wring out of those adjustments. So we were very resistant, and the secretary was resistant to creating the winners and losers that this created. So we moved on. Next slide. To the 3 options. First option was track 3 with those large swings, population-based payments using the practice average HCC refined scores, the performance-based adjustment framework with asymmetric risk, including a -10% downside risk, and then an upside that was yet to be defined. It could be somewhere between 25 or 50%, and sticking to a flat fee of $40.82. And the flat fee was really probably the reason for that large unreducible variation, and practice level revenue variations would remain, and that program would begin in 2023. So that was, that was really where we stopped. So option 1 was accept where we stopped and accept the large practice level variations. Option 2 was suggested by CMMI that we take the current track 2 but modify it, and the modification would be essentially adding a total cost of care measure to the current performance-based incentive, not changing any of the other features of track 2 except adding that measure, making that 25% of the performance-based incentive, maintaining the quality portion of that at 50%, and reduce the utilization portion to 25%. And then that would introduce more practice accountability to the total cost of care, which was one of the features that was in either of these measures, and that care management fees and PBIP and comprehensive primary care payments would stay the same, and this would begin in 2022. The third option was that there would be no changes. We would keep everything exactly as it was and is, and CM indicated that this will not put MDPCP in the model in good position for expansion. And they were very clear that that is a reminder that in considering whether to expand the overall total cost of care, that CMS will examine cost and quality results, as well as whether the total cost of care model achieved its other objectives, including whether it extended total cost of care accountability. So that was an appended to their last communication to us. So I think at this point we're on the program management office and the state perspective are really inclined to say that we're leaning very heavily on the second option, which is to add some total cost of care responsibility or accountability to the current model, and not inclined to keep things as they are because of the really very chilling comments from CMMI about keeping things as they are, and really not inclined to impose very large unmitigated practice level changes in Medicare revenue to the practices in the program under the option 1 either. So we're very, very strongly leaning toward option 2. And I'll just stop there.
Howard.
Dr.
Yes, I apologize. I'll turn on my picture. I know that you have a high threshold for going back to them with an option 4, but can I just ask a really simple-minded question?
Any question is acceptable.
Why not? I'm very open to option 2, but why not have an option 4 where you simply go with what Maryland wanted to do, but cap the top and the bottom? So can you keep it budget neutral by minimizing the swing at each end, right? There's simply a cap to how much revenue change a practice can experience, either on the upside or the downside. Just a simple-minded suggestion.
Yeah, so thank you. It's a good suggestion, and I think we've entertained those kinds of caps to do that. But I don't think that was acceptable at this point to CMMI. So I think to be absolutely frank, I think where we are now after looking at many of the different ways to in essence skin this cat is that we've heard pretty clearly from our colleagues at CMMI that these are the 3 options that you have. It's time to choose one of those 3. So.
Thank you. And Tracy Laval, then Dr. Berenson.
Yeah, thank you. So I just wanted to weigh in here and thank you for these clear options. We have heard from CMS that CMS considers the Maryland Primary Care Program a really important part of the Maryland model. So from our point of view, we think it's really important that we choose an option that CMMI will view favorably. I think for the whole state, it's critical that whatever we choose for MDPCP, it's a viable option. We don't want to put the entire model at risk by not choosing something that is favorable. So along those lines, I have a couple of questions. I'm going to start kind of in reverse order. I'm hoping that at the end of today, we'll get to a question, or we'll get to a point where we say, what is the process for deciding between option 1 and option 2? I can say that for the, we're leaning towards option 2. Debbie Kuchka-Craig is going to be late if she doesn't make it today. She had another appointment. But she favors option 2 also. The MedStar system favors option 2. That's a direction that we're leaning. But I'm wondering, Dr. Haft, if you could talk a little bit about whether CMMI views both options, option 1 and 2, equally favorable. Does that, typically they want to see us demonstrating movement. So that's one question. And then the other question is, will CMMI, if we choose option 2, are they going to require that we go to option 3 in 2023? So, I note that option 2 says start in 2022, option 1 is in 2023. So will they require that? And then again, most importantly, at the end of this, I hope we talk about how we're going to make this decision between the 2 options. Thank you.
Dr. Berenson.
Yeah, I didn't hear whether these 2 options, other than the status quo that CMMI is sort of demanding, solves the winners and losers problem. I mean, is that what they are claiming? Is that these 2 options somehow address the concern that you guys couldn't solve?
So Dr. Berenson, option 1 is the winners and losers. So that is that's okay. The issue. Option 2 solves the problem. It basically keeps the payments the same. People will win or lose based on their performance, not based on simply a transition from one track to another.
But they can model how the performance of the practices, how they do on total cost of care, or did they, to determine that this would actually result in fewer winners and losers?
So it would be there would be a piece of the performance-based incentive, about a quarter of that, which is currently in track 2 is $4. So it would be $1 of that, which would be at risk based on total cost of care. The answer to how they would do hasn't been modeled because we don't yet have the any visibility on the actual measure that's going to be used. We believe that it'll be the TPCC measure that MIPS uses, but hasn't been used in this kind of venue before. It's being used in the advanced tracks in primary care first, but of course that just launched, and I don't think it's even used in the first year of their model. So we don't really know exactly how to model that, but there's some details, and I won't go into the dense details, but in the TPCC model, total per capita cost model, the benchmarks for the hospital side in states that are rate related uses an average for the nation for the hospital costs rather than individual costs. So if they adhere to that, I think it would be probably a fairly I think it would be a fairly level playing field in Maryland.
Okay. Dr. Haft, could I circle back to Tracy's question about progression? She raised a point about if we were to go with, say, option 2, is there a requirement to progression to option 1?
No, we've not heard that at all. So this was, and I believe what we did here is that we needed to make they wanted us to make some modification within the performance period that would allow us to have some run on several years of what that option looked like for the ability to be measured for the model by Mathematica, et cetera. So I think that I didn't hear any of their discussion, anything about having this and then a subsequent year, yet another modification.
So we have one unknown hand raised. If that individual could go first, I think they're on the telephone. Then we had Will, and then Dr. Behrens. Okay, we can come back to the caller on the telephone. Will.
Great, thank you, David. I guess I was just also curious into the first part of Tracy's question, which I think was, CMMI pushed us pretty hard for a track 3 submission. We are now, I think, in hearing that they're okay with a track 2 suggestion, but presumably they view that less favorably than the track 3 suggestion. And so I guess how much of a cost are we incurring in CMMI's view of this model by dropping from a track 2 to a track 3 proposal?
So, Will, I think anyone has a way of understanding that. I think that would go to the new leadership at CMMI. But I'll tell you personally, I feel if the state what HSCRC and the hospitals have done in terms of savings and what the MDPCP program has done in terms of very broad statewide transformation and reducing avoidable admissions and the work during COVID, that it would really be hard for me to see a future where a model as successful as this one would be looked at by any leadership in CMMI in other than a favorable way. So the rest of it is, I think interesting to discuss and think about, what they're thinking or what they'd like to do. Clearly there's movement to say we would like everything be primary care first, but no one knows what primary care first is going to look like, and the word on the street is or very few people are going to be joining primary care first, so they probably won't be able to tell how good it is anyway.
So Howard, I do think that's a little optimistic. So having been on the other side, I can tell you I don't think the view of the Maryland model is universally favorable. I also don't think that CMMI would send a message of this sort to the state without having their leadership bought in. And so I think there is, some trade-off, although how big the trade-off is, I think it's a fair question that nobody can really know.
Will, can I push back on that a little bit? I have reason to believe that they don't always connect to their leadership as directly and frankly as we assume they do. I have encountered inconsistencies in what their leadership is hearing and what the state is hearing from the team. So I just want to caution us there, and that we're going to need to tuck and tie every communication. That said, I agree with you that, there's a lot of ambivalence in the agency about this waiver. On the other hand, the momentum is to the state's advantage here, which is not to say that we shouldn't be responsive to what they say they want, but I don't think they have much appetite for alienating Maryland at this point, especially when they don't have a really viable national primary care model that is getting, positive reviews from the marketplace. Primary Care First is not that.
Dr. Berenson. Thank you, Dr. Fong.
I just wanted to clarify, option 1 was what we proposed. Is that correct?
No, actually, option 1 was it was a framework that we used, but we had proposed that it would only be acceptable if there was not a significant level of practice level total primary care payment variation. So we were not able to achieve that with any of the modifications of that option 1.
Well, I'm very confused.
We proposed that the flat fee would not be $40.
Well, that's exactly what I looked at. So where does this option 1 come from?
So this was CMMI's. This was where they landed and said, no,
okay.
we're stuck on the flat fee of $40.82.
All right, so that's so because when you responded earlier, I thought you said that option 1 was our option, and I didn't think it was our option. And
it was except for
$40.82 is a non-starter, and
right.
So I would reject option 1. It sounds like they want us to do option 2, and I don't know that we have a choice.
So Howard, maybe the distinction in option 1 from what they proposed originally was that they did yield on the tiering. We had proposed patient-based risk and
not practice-based.
Not practice-based. They had yielded a little bit by allowing for more practice tiers. That was something of an accommodation, but didn't move it all the way to the proposal that Maryland had put forward. Is that kind of correct, Dr. Happ?
Yeah, I think that's exactly right.
Thank you.
Dr. Barb, were you interested in making a comment?
No, I'm good. I'm following. I was a little confused, and Bob asked the questions I was going to pose, the difference between option 1 and what we had proposed. Whether we had modeled option 2, and the answer I heard was no. We don't know how that would play out, right?
Dr. Happ?
So no, we don't. But it's substantial. The change in that is entirely on the performance side. And so it shifts some of the weight of the performance measures into a total cost of care measure. So that's the piece that's unknown. So if we modeled it, it would be 25% of the $4 PBIP or $1 per beneficiary per month, and whatever what we haven't modeled is what the average retention would be on that. If it's typical, if it's the same as the other measures that we've had in the past, it lands right around 68% for the program. So we'd be looking at 32% of retention that would be reverted on the average. But we don't know because we have no experience with this total per capita cost measure.
And so we have one hand raised. Before we get there, to invite Stacia Cohen from a different perspective. Any comment here?
Yeah, I'm still trying to process the difference between option 1 and option 2 practically. So as I looked at track 3, I thought that option 1, they were saying this is what aligns to PCF. Don't I have that correct? Like option 1 is aligned to PCF and all the elements of it. Option 2 is put increased risk and a total cost of care measure into the PBIP. And option 3 is do nothing but put the whole waiver at risk. Am I characterizing that in a way consistent with what other people are understanding as well?
Dr. Haft?
Yeah, I think option one is primary care first. Option two is basically the current model that we're using, but adding a total cost of care measure.
And I think we have time for the question that Tracy Laval has before we turn this back to Dr. Riedman and we begin to wind down given our time. Tracy.
Yeah. So my questions really just are, what is our process for deciding between option 1 and 2, and what are the next steps?
Very good. You're anticipating the agenda quite well. That's next up. Dr. Riedman.
So thanks everyone for the input. I think it's really helpful. It's clear from our conversations, or I'm pretty sure it's clear in it from the discussions with the committee too, that, you know, we spent a lot of time discussing the primary care first program, and I thought making reasonable recommendations to modify it so that it would work for the state. And basically they came back with pretty much the same proposal that we started off with, which is, for all the reasons that we've discussed today and that we discussed over the last couple of months, just really a non-starter. I think from a physician standpoint, the other side of the second option, option 2, is that even though I as a physician and one of the physicians at risk for the total cost of care, I find it frustrating that we have very little control truly on the control of the total cost of care. So we're being held responsible, and we've obviously had those conversations numerous times with this committee about how the physicians feel about this, and we're certainly willing to control the things we can control, but when we're being held responsible for things that we have no control over, that gets a little frustrating. On the other hand, the second option is certainly a more clear-cut, very straightforward. At least the risk is, how that risk is measured is a little bit more complex, but I think it's much more straightforward than option number 1 too. I think the physicians will understand that, and we've always had those conversations too, that having a program that's simplified that the physicians can understand goes a long way. So where the option 2 may not be the best, there is that total cost of care. I think it's certainly livable, and the questions I think are going to be raised, and Dr. Haft has already touched on those, and so is Tracy, that, you know, what does this mean for 2023 and 24 and 25? I don't think we're going to know that yet, but I would guess that the best option right now, unless someone on the committee has a significant objection to it, would be that we would give this a week. We wanted to get this meeting out this week. We were actually going to try to do it last week, I think, as some people know, but we were still getting feedback from CMMI at that point and weren't ready to have the presentation. But I'd like to give this, we have to make a decision by the 14th, a week for the committee members to, if you have objections to, basically, I would say to option number 2, that you express those to us or with a phone call or an email. Otherwise, it sounds like the committee feels the same way that those who have been involved with this for the last couple of weeks feel. That track, at least the option number 2 is where we should go. So that would be my suggestion to make this decision, is we go with track 2 unless someone raises some significant objections, which we could do. And worst case, if it were some significant objections, we have another week to make a decision and have a promptu meeting. I don't think from discussion today that we're going to need to do that. So that would be my suggestion, and I'll turn it back to you, David.
Okay, very good. So I think on the table here is if the committee can begin to reflect a little bit about what you've heard. If there are questions you have that would influence where you sort of land, please reach out to any of us, Dr. Haft, Dr. Riedman, myself, our executive director, Mr. Steffen. We would be happy to answer any questions. Otherwise, we will use the date of May 11th at end of business day as sort of the cutoff. If we do hear anything else from CMI, I believe Dr. Haft has some questions still that he's planning to either ask or has out for answers. We'll share those back with you. And if there's a need to reconvene on the 11th, we would ask that you just hold that evening hour aside in the event that that's a possibility, and we would get back to you. It could be as late as Friday or even early on Monday, but if we can just mark it as a tentative time block, at least we'll know in the event that we should reconvene. I believe, just for the record, we had a couple of folks join late. Dr. Berkowitz, Kathy Chapman, Laura Goodman, and Dr. Wiedner. Great to see you all virtually. With that, Melanie, did you have any comments? Oh, Dr. Reedman.
No, I think Stacia raised her hand.
Oh, Stacia.
Yeah, I did. I just had one more question in between considering options 1 and options 2.
Okay.
And that is option 1, wouldn't that require that to go through the clearance process? And so technically be a more complicated implementation that didn't have any guarantees of approval, and that option 2 we could handle programmatically by just making those adjustments into the program. Is that an accurate way to characterize those?
That's correct.
Okay, that also argues then for option 2, because I'm not sure option 1 could get through clearance anyways.
Right, right. And I think Jean brings up a good point for those of you who saw this message. Ben, you comment?
No comment.
Okay. All right. With that, Melanie, do we have any closing operations remarks you can make?
No, just, if it's okay with you, what we could do is they can route the questions through me, and then I can send them to whoever, and I can collect any feedback or questions or anything throughout the next few days.
Okay, that's very good. So thank you. And Dr. Reedman, are we satisfied, or is there any comments you'd like to make?
No, I just want to in particular remind everybody, or at least thank them again for all of the work we did last year. That was a lot of effort. I know it was a lot of time for everybody, and I again appreciate it. After all that, we came back to where we were before, but again, I don't want to leave the meeting without giving my appreciation for all the time and effort everybody's put into this. In particular, Howard and David and all the staff basically up at the Maryland Healthcare Commission done an excellent job with this. So I just want to thank them again.
Wonderful. And Dr. Haft, thank you for the presentation. Everyone, we look forward to talking with you one way or the other between now and next Tuesday.
Thank you very much.
Meeting adjourned.